All right, cool.
I'm great.
Is it 2? Is it
It
that
is two
time?
o'clock, sir.
Oh my gosh, 2:01.
Oh,
Hi,
one.
everybody. Uh, Thank you so much for making the time to uh to learn something and to go over some I think these in particular are very informative and illustrative cases. Um, if you haven't watched a webinar yet, my name's Eric Shirtliff. I'm one of the trauma surgeons at Maine Medical Center. And as part of what we do as a trauma service at a level 1 trauma center, we um, try to make sure that we are in contact with you all, being the EMS providers of the great state of Maine, to um, to to be doing our part to feed things back and to work with education. So that's what these webinars are for. If you do have a case of interest at your agency that you would like to see presented here, or then the route to get that to my attention is to have your chief email me. My email is there at the bottom of the slide, and I can usually incorporate that into some sort of pre-hospital management lecture, and then we can go over images. And I find this is at least the feedback that we've been getting is this is really instructive. So at any rate, that is the way we have to do it as far as information sharing goes. But let's get into it. So this presentation focuses on spinal cord injury, complex extremity injury, and chest injury. The first case is really a case that is an excellent illustration and demonstration of good management of complex extremity trauma in the field. Then the second case gets into chest injury, complex chest injury, and spinal cord injury. So let's go to these are the objectives. Um, as always, correlating pre-hospital physical exam findings with injuries identified by imaging is useful. I think that's the request I get the most when I speak with you all. I'd love to see what the images looked like, or gosh, what is, you're describing this injury. What does that look like? So that's my effort here to do that. And then we generally review the broad strokes of the EMS protocol for management of traumatic injuries. So today we'll review complex extremity trauma and hemorrhagic shock, pre-hospital management of severe traumatic brain injury and brain death. Although, actually, I apologize. That third one we will not be reviewing with this particular presentation, but that will come up again in future webinars. And then, so the last one, the third one, would be pre-hospital assessment management of severe spinal and chest injury. So, first case. This is a 30s to 50s age female who was in a high-speed motor vehicle collision. When the EMS arrived on scene, the patient had been extricated from her car by bystanders. There were multiple vehicles involved, several of which were on fire. Um, on scene, when EMS arrived, the patient was semi-conscious. Initial vital signs concerning for tachypnea, with greater than 40 respirations a minute, GCS of 13, pulse 73, blood pressure 151 systolic. On physical exam, the left leg was grossly deformed, and there was active hemorrhage at the site of an open distal femur fracture. On scene, they estimated about 2 liters of blood loss on the ground. A tourniquet was applied to the thigh, proximal to the fracture and hemorrhage, and that achieved initial hemostasis. There were also signs of closed head injury. The right wrist was deformed, but there was a distal pulse present. The thoracoabdominal exam was benign. The pelvis was stable. With tenderness to the left hip on palpation. The patient reported severe left lower extremity pain, was agitated, combative, and tried to remove the tourniquet on the way to the hospital. So, you just looking at this, things you notice. Patient's normotensive without tachycardia, but breathing rapidly, and there's a significant blood loss on scene. As you'll see, those vital signs don't stay that way. The total scene time was 13 minutes, and given the extent of this patient's injuries, that's pretty impressive. And they got moving quickly to the nearest emergency department. Uh, okay, so en route, the hemorrhage recurred at the open fracture, but the pedal pulse was absent on exam, and so that is an example of a well-applied tourniquet. If there's no distal blood flow, that's one way to confirm that your tourniquet is actually effective, is to check the distal pulses. Quick clot was inserted into the wound and applied an internal tamponade to the wound, and a pressure dressing was applied over this, and this achieved hemostasis. Uh, as she deteriorated en route, the sinus tachycardia crested 130, blood pressures decreased significantly by 30 points systolic to 120s. Wide bore IV access was obtained. TXA was administered. Initial volume resuscitation was also initiated, proceeding down the hemorrhagic shock pathway. The oxygen level was saturations were greater than 9% with high concentration oxygen by a non-rebreather the entire trip, which is really important if you have any concerns for a closed head injury. We know that a single episode of hypoxia to severe brain injury below 90% can lead to a fourfold increase in mortality. They noted that while the patient was in respiratory distress, the exam did show equal chest rise without tracheal deviation or JVD. So appropriately, there was no decompression initiated for this because it wouldn't have helped with that situation. As the team proceeded to the hospital, GCS declined to 7 by the time they arrived. So rapid transport here was critical to the patient's survival. When they presented to the hospital, they were intubated immediately by RSI. MTP was initiated because the patient further deteriorated in terms of her hemodynamics. The GCS decline, as I mentioned, went from 13 to 7. Everything, the spines was immobilized completely. And then oxygenation and sedation were maintained once the patient was ventilated. There was an open fracture that had initially been worked on the scene. And as it turns out, the hemostasis that was achieved by the dressing maintained after the tourniquet release, which is ideal. It's exactly what you want to happen. And the patient also received 2 grams of ceftriaxone for open fractures. Patient was stabilized, imaging was obtained, and then they were transported to us via life flight, remaining stable and off vasopressors. So, you have somebody who's probably, tilting into class 3 hemorrhagic shock here, and because of the excellent hemostasis that the field team achieved, patient after 4 units total was able to completely stabilize and stay off vasopressors and transfer. So that kind of fits too. We think about a unit of blood is about 350 cc's, so you're about 1,400 total volume given plus the 600 of IV fluids. That approximates about 2 liters, which was the estimation on scene for what was lost. So, again, the restoring not only the lost blood products, but also achieving euvolemia. That's how we stayed off the vasopressors, despite the fact the patient was sedated, and all of those things that can also provoke hypotension. The injuries that were identified on CT were traumatic subarachnoid and subdural hemorrhages. They were small and subtle. There was a grade 2 splenic laceration without really significant hemoperitoneum or significant blood loss. The major injuries were really on the left lower extremity. There was a left femoral neck fracture. There was a open left distal femur, left tubular plateau as well. And the images will kind of focus on that in the next couple of slides. There was also a right wrist fracture and a left wrist fracture. So these were the pictures from the trauma bay. This is looking at the front of the leg. You can see it's grossly deformed and very swollen. Sorry, these don't project all that well. They come from kind of small pictures in the media, but you can see how the femur poked through here. So there's an open distal femur here. And then this is the open, more proximal left thigh with this large gaping wound that was really effectively managed with compression and hemostatic dressings. And this is a better look at that distal where the distal femur came out through the through the skin. So this is a really badly injured left lower extremity, about the worst I've seen since I've been here. So looking at the scans, we got a CTA because despite the fact that we were able to palpate pulses, the injury is so significant, you can still have formation of a pseudoaneurysm, which is basically just a contained laceration of the blood vessel with this extent of distortion of the limb once the bone is fractured in a couple of places. So just to get some orientation here, this is the left femoral artery coming down and starting to branch. And then this is the vein returning. And this is very swollen, injured musculature here. And this is kind of a little bit of a slice of that distal fracture. Here you can see the proximal fracture right at the surgical neck of the femur. I mean, it's a significant amount of force to fracture this bone in this way. And you also see a little bit of the distal here. And then this is a sort of a side view where you can see how that bone snapped and then this knife edge kind of poked out through here. Here's a little bit of quick clot stuffed into that. And so this is the course of the femoral and the popliteal artery. And I kind of showed it in sequence like we're just looking at it in one of those flip books, like a cartoon. But here you can see the distal femoral artery coming out of what's called the adductor hiatus, which is where the adductor muscles split and allow that vessel to transmit from the inner thigh posteriorly to the back of the knee, where it becomes the popliteal artery. And you can see it's curving down here. It curves down around past the fracture, and this is actually a very mobile blood vessel in this location, which probably is why there really wasn't a significant injury to the artery at all. Here you can see the artery coming here. There is a bone fragment here that's literally abutting the vessel, but you can see there's no this kind of light color. The reason it has that light color is that there's contrast in it. And if there were a significant injury to the vessel, you would see contrast leaking out of there. Sometimes you can have a partial disruption of the vessel wall where you will still have pulses transmitted distally. So in a severely injured limb like this, even if we have pulses, we tend to get this level of imaging. And now you can see it's made it to the back. This is the popliteal artery here. The brighter is the artery, the kind of dimmer is the vein, and it's still transmitting blood, and it's making it down distal to where the tibial plateau is also fractured. And then here you can just see it does transmit past the injury. And this radiopaque stuff is the dressing that's wadded into there. And so, with these lateral injuries, like we saw, going back to the pictures, the point I'm making with the course of the artery is that it actually it's very well protected by the evolution of our bodies to keep it out of harm's way in the thigh. So generally over here, what you're going to get is branch bleeding from profundifemoris vessels. So you can still have arterial bleeding, you still have significant blood loss from an open thigh fracture. And in fact, an open thigh fracture can certainly be life-threatening. Even a closed thigh fracture where there's significant hemorrhage, we can hide two almost 3 liters in a thigh compartment. So these are definitely severe life-threatening injuries that need to be taken seriously. And I just want to kind of applaud the field team for going high and tight with the tourniquet, and then when that wasn't working because there was probably some compression on the venous outflow, which is probably why you saw the recurrent hemorrhage, that they were in that tends to be a lower pressure hemorrhage, right? And so that is controllable with compression. And so they reacted exactly the right way to control that as well. And I got a patient that was in the process of stabilizing by the time they got to the hospital. So there's just some notes just in general about extremity trauma management. Um, we recommend a stepwise approach, initially beginning with manual pressure, that will control even a bleeding aorta in the OR, just as a kind of thought reference. And pressure dressing, and what I mean by pressure dressing, and I think I got a chance to do this with some of you in November when we had the EMS conference. The goal is to absolutely fill the void that's created by the wound, and her wound's a really good example of just a large defect that extends through multiple tissue layers, and that ideally what you want to do is to push all the way to the base of that wound, and then bring the dressing out in circular motion, compressing it against the sides of the wound, and then fill the center afterwards, because that allows full contact of the hemostatic dressing to the bleeding surfaces of the wound. Because a lot of times it may not even be a named vessel, but if you have enough exposed tissue, you can still get yourself into a situation where you have evolving hemorrhagic shock from an extremity injury. Um, If the bleeding persists, manual pressure proximal to the injury, and then if bleeding continues, manual tourniquet. It seems like in this case, all of those things were sort of done at once, which is appropriate. The important things with the tourniquet, obviously, is like it is important to note the time that you apply it. That's critical, because we know we have about 6 to 8 hours warm ischemic time before we have to do something to revascularize an injured extremity. Um, and the, this is also really important. A properly applied tourniquet occludes arterial inflow, and in general, the 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 extremity won't swell. If you, I mean, I guess if you were only to occlude the venous side, it would swell, but if you apply something circumferentially around, it's pretty hard to just occlude a venous system. I guess the point this is making is to really make sure that you lose distal pulses once the tourniquet's applied, because then you've occluded the artery. But then you do see some cyanosis and modeling of the extremity, but you won't see swelling if you in fact have the artery compressed. Um, and ischemia of any kind hurts. And so that's another indication that the tourniquet's effective. If you've really, compromised arterial inflow to the tissue of the injured extremity, it will hurt a lot. And so we'll talk about that here kind of in the next. Um, I have some notes on tourniquets here in the next slide, I think. But this is actually a different patient, but this was a patient with a large Merle-Lavallee lesion that basically sheared all the soft tissue off the underlying musculature. We're looking at the thigh muscles here. These are the quads that come down. This is the medial adductor compartment. So we know that the femoral artery is over here somewhere, but it's not actually hemorrhaging.
And then this is the lateral thigh compartment over here. And you can see this patient actually was taken to the OR because they were hemodynamically unstable, and that was refractory to transfusion. So one of our surgeons had to um, get in here and deal with all of the small bleeding vessels and the large soft tissue defect to achieve hemodynamic stability and hemostasis in this gigantic wound. And so we do these types of wounds you'll see if someone gets dragged by a vehicle, motorcycles, you'll see this. Sometimes older folks, they have they have less collagen integrity in the soft tissues, and so the kind of classic one we see there is when an older person falls down the stairs, you'll see like gluteal and flank Morel Lavallée lesions where the tissue just shears right off the underlying muscle. Um, but really, the only way to deal with this is to open it up, tie off things that are large, cauterize what's not, and then wrap it. And so that's what was done with this patient. But in general, for large open wounds, packing is going to be the way, if also in addition to a tourniquet, as we kind of talked about our patient. But obviously, you have to completely expose the wound to know where to pack it. Excess pooled blood can be in the way, but if you see clot, it's better to leave that. That's only going to help you. And if you can locate the source of the most active bleeding, that is the place that should be most tightly packed with the most pressure. Thing you can use anything. Ideally, it's clean. I mean, the best thing is hemostatic dressing, but if that's not available, a gauze roll, clean cloth, anything to apply compression to the bleeding surface, and stuff it right into the wound. Obviously, protect yourself. You don't want to cut a finger on a bone, but you essentially with a large open wound, you are not going to harm them by pushing deeply into the wound. What will harm them is if they don't have adequate compression against the hemorrhaging surface. And it, as promised, tourniquet notes. I think the EMS protocol is high and tight. That's never wrong. There are sometimes distal injuries that might be it's like, say for example, this injury was down here and it was smaller. You could potentially apply, excuse me, a tourniquet a couple of inches proximal, as long as it wasn't over a joint. What that buys you is less ischemic tissue. So it's not the whole leg that's ischemic, it's just that one part. But honestly, I think for the purposes of emergent management and transport, a high and tight tourniquet generally is the way to go, especially you can see this one's applied here. Um, and that's really right where we looked at the anatomy, and we can that vessel comes out right on this side here, and then you know where to find the femoral pulse. So that is a good spot because you can get direct compression using the femur sort of as the buttress and the fulcrum. Um, in general, if the first one doesn't work, you go higher. If they both fail, you revert to two-handed manual compression with hemostatic gauze. That's the general pathway, which is, again, illustrated by the case. They had a tourniquet, it was working, then it started bleeding again, and they went right back to compression with the hemostatic dressing, and that worked effectively. Um, so here's the common tourniquet pitfalls, and these are important. Not using one or waiting too long to apply it when there's life-threatening bleeding. I think that's that's really the bottom line for all of these things. If you think about it, use it. Um, no one ever died from a tourniquet being applied. People have died from exsanguinating hemorrhage from lower extremity wounds. And another thing is that it does really hurt the patient. So if you apply it, and nobody wants to hurt their patients, right? But if you don't apply it tight enough to stop hemorrhage, then it hurts and it's not effective. So in general, um, you'll need obviously ALS to help manage the pain. In the field, it seems like ketamine and fentanyl, if the patient's relatively stable, is pretty effective for this. If you need it, use a second. Go above where your first is applied. Definitely don't loosen a tourniquet. In general, like I said, you have 6 to 8 hours to definitive hemorrhage control. So even if you're coming from very, very far north, in general, people can make it to a trauma center to deal with this, or at least to a place where a physician can evaluate the wound in that time frame, within that time frame. Um, and so in general, especially if you're down here in the southeast, loosening a tourniquet is never something that you need to do. And again, only a paramedic or physician should loosen or remove a tourniquet. And I would say if a paramedic is in a position where they think they should loosen a tourniquet, contacting online medical control for some guidance would be helpful in that situation. Um, Okay, I just want to stop here for the second case. Eric, are there any questions coming up in the feed? That's the one problem with the slideshow. I can't see the feed.
I have, you want the second tourniquet about an inch, maybe two from the first, right? So there's not a dead spot between the two. Questions about placing two.
Um, there can be space in between. I think that the main point is just to be proximal to where the initial tourniquet's placed. Um,
And that is what we have. Oh, there we go. Hold on. Another one. What are some circumstances a paramedic could loosen the tourniquet?
I really can't think of any. It would be, um, you know, I can't even think of that scenario. In general, it would be better if the patient's blood loss is so severe that that tourniquet is keeping them alive. It would be better to lose the limb over the life. Um, I can't think of one, although I'm sure there's something that might occur to me after I'm done giving the presentation. But in general, if you're having that question, you should do any of that sort of thing should be done with physician guidance, either over the radio or however it is you can get in contact with online medical control.
Most of the places that we see, and it's the long care term where they're not going to be able to feed the patient for long periods of time.
Yeah.
Yeah.
And like I
I
said,
think
if someone's that severely injured, it would probably be better to lose the limb.
And I believe that covers the questions for as of now.
Cool. Thanks, guys. So case two, 50s, 70s male, blunt injury to the thoracic spine and chest. Patient struck a ski lift pole at high speed while skiing. He presented to the waiting EMS via the sled and ski patrol. The spine had been immobilized by ski patrol with a cervical collar and backboard. The patient was protecting his airway, however, he was in acute hypoxic respiratory failure with tachypnea to 30 breaths per minute and SATs in the 84% range, despite being on a non-rebreather. He had equal chest rise and breath sounds bilaterally, which is kind of interesting, and we'll talk about that nuance here as we look at this case. Initially, his blood pressure, he was hypotensive, systolics 80s, but there was no tachycardia, which is also interesting. We'll talk about that too. His GCS was 15. However, he had bilateral lower extremity flaccid paralysis and initially lost his sensation below the umbilicus. As his course went on, he lost sensation more cephalad, and his final loss of sensation was at the xiphoid. Um, this was also a very quick transport to a rendezvous with life flight, but in that time frame, peripheral wide bore RVs were placed. Volume resuscitation was initiated, and the patient did have a transient response with the pressure improving to 110. And he still continued to have sinus bradycardia into the 40s, which is telling, and we'll talk about why. The patient was then transferred to life flight and had several episodes of both bradycardia and hypotension while transfer. Again, with a good response to blood transfusions, he got a unit of REDS, unit of FFP, and TXA from Life Flight. And then his oxygenation and tachypnea also improved with pain control and supplemental oxygen, continued by non-rebreather. And by improvement, I mean like he maintained over 90s and his rates dropped down to the 20s, but he was still really struggling. And the main thing he was saying was it's my chest, my right chest, and back. When he presented to us, his initial EFAS was negative for abdominal hemorrhage, and he also had lung slide bilaterally when we looked with the ultrasound. However, the chest X-ray showed extensive subcutaneous air, which showed significant lung and chest wall injury. And we'll see it's a picture's worth 1,000 words. But what happens with pneumothoraces and really severe blunt chest injury is that the pneumothorax is at higher pressure than both the pleural space and the subcutaneous space, and so that higher pressure air infiltrates everywhere it can go. If the chest wall isn't severely injured enough, or I should say, if the chest wall is severely injured enough that the intercostal muscles, the muscles in between the ribs, rip apart, that allows a pathway for that higher pressure air to escape from the chest and get into the subcutaneous tissue and on the muscles and everywhere else. And so I'll show you on the scan. We'll be able to see all of the places that air can go with this type of injury, because he had probably, one of the most severe chest injuries I've ever seen. He he did get bilateral chest tubes in the emergency department with conscious sedation. We used ketamine too, and he had emergent neurosurgical consultation. But we did not actually intubate him until he went to the OR. But he was admitted to the ICU for ongoing support. I think it was at that point very important to be able to examine him neurologically. And he did not actually progress into full-blown failure initially, which when you see the scans is actually kind of a testament to how healthy this individual was before he was injured. So these are his injuries. He had an unstable chance fracture of T4 with spinal canal narrowing. And there was some air in the epidural space between the sac and the bone. And there was retrolisthesis of T3 on 4. And I'll show you what that looks like here in a little bit. He had a T11 body fracture, which really didn't contribute to his overall course. And then he had transverse process fractures as well. In the chest, he had severely displaced right-sided ribs in the posterior ribs 5 through 12, anterolateral 7 through 10. So he had a flail segment on the right side, a significant flail segment. And basically, the whole chest was crushed. And he also had multiple left rib fractures, as well as a flail segment on that side too. He had traumatic pneumatoceles in the right lower lobe, which I'll show you what that looks like. And then he had hemopneumothoraces bilaterally, and a very extensive subcutaneous emphysema, also pneumomediastinum, and then a scapular fracture as well, which is basically the scapula broke and impacted into the chest, and the chest wall broke around it. So here we go. So this is the spinal injury here. You can see how this is the lamina here, and this is the pedicle here. If we're looking at a vertebrae in cross section. I always imagine when I'm looking at an axial CT, which is what this is, that I'm standing, or I'm like laying on the ground looking up at the patient. That sort of helps with orientation. So this is right side, this is left side. This is the front, that's the sternum, this is the back. These are the scapulae. You can see the scapular fracture here. But here you can see this is the spinal canal. This is where the spinal cord is, and this is this is severely impinged, and there's a complete injury at this side. And we'll talk about why thoracic spinal canal is actually more prone to this than the other parts of the spinal canal. And you can see the air is infiltrating all through these are the paraspinal muscles, and it's all into the back and actually across the other side. So this is a really devastating injury at the level of T4. And you can see what it does to the spinal canal, and this tightness here is why why he was sort of instantly paralyzed. And then the level of the sensory loss moved up accordingly, as the injury completed itself. Um, this is a little more subtle, but this is an MRI from the side. You can see this slice kind of doesn't do it justice, but you can see where the impingement is here. This is the cord. You can just see how tight that space is in general, especially higher up. This is not, but I think that why this injury was so devastating for him is that um, what you can see is retrolesthesis of 3 on 4. So this is 4, and 3 is backwards. And so what happened was not only was there this kink here, but this at the moment of impact pushed back into the cord and basically just took the cord out right at this level. Um, and you can see that there's ligamentous disruption too. Like there's the anterior longitudinal ligament here that should hold all of this together. But if you have retrolesthesis, that's a really unstable situation for the spine. And at any rate, that's what you can see here. And then moving on to talk a little bit about the chest. You can see that these ribs are not where they're supposed to be. This is supposed to be continuous with this. You can see, shards here. You can see the pneumos here. You can see some of the hemothorax layering in here. You can see bruising of the lung. This is pulmonary contusion here on both sides. And then you can also see this air just infiltrating everywhere. So that indicates that not only do you have a lung injury, but you also have a disruption in the chest wall where the air can escape. And so that is, that's what we're looking at on this right side here. And then the traumatic pneumatocele is really essentially where the injury is. That lung has been disrupted, and that's air within the lung tissue where the laceration isn't able to decompress out into the outside. So it's an internal injury where the air is actually pushing back into the lung tissue. And you can see 1, 2, 3 of them there. Yeah, it's bad. This is bad posterior fracture and probably the cause of the laceration in the pneumatocele. Um, And this is a 3D reconstruction with the scapula removed. So it's sort of a cheating view. The scapula would be here. And you can tell, like, when the scapula impacts the back of the chest wall, it breaks behind it and in front of it. And that's what we saw here. This is the patient's right side. And so these are all posterior fractures, really close to the spine in the back. But what happens with these is the spine is sort of a fixed column, and the ribs are really supported ligamenously. So what happens is the anterior segment, or this part of the chest, pushes into the lung. It kind of falls off, and to fix it, we have to pull it out and hang it with plates off of here. And I've got a slide showing that too. You can see the anterior fractures too. Really severe. The ribs are subluxed, and he's got a flail segment here, buccal fractures here. This whole right side of his chest was destroyed. And then on the left side, a little less, but still significant. There's a lot of displacement, and whenever we see more than 3 contiguous rib fractures, we know the chest is unstable, and he has 1, 2, 3, 4, 5, 6, 7, 8. So again, this, and actually at operation, we found that there were anterior fractures too on this side. So he also had a flail segment on this side that you can't really appreciate from the CT scan. So this was after the operation. These are where the spine surgeons stabilize the spine. And so even if there's a complete spinal cord injury, that we will still stabilize it because he'll need this to be able to use a wheelchair in the future. He'll need his spine stabilized. And then we went after the right side first. It was the more severely injured. So these are the right side plates. This, you can see we were used the plates to elevate those fractured ribs out of the chest and stabilize them with the plates to sort of hang things back where they're supposed to be so they can heal. And then these were the anterior fractures. And then on the left side, we went back again a second time to fix this. You can see some of these fractures required longer plates because again, we found all these anterior fractures that were very unstable when we were in the OR. So at any rate, the chest is stabilized, which is also important. It sort of helps him recover his ability to, again, not only it prevents downstream consequences with the lungs, but also stabilizes things so that when he moves on to physical therapy, he'll be able to have a stable chest wall to use because he's going to be using his arms in a whole new way, given the level of his spine injury. So a few things about spinal cord injury. In the run sheet, the medics noted that he was able to feel below the umbilicus. And then when he got here, the neurosurgery PA felt like he was able to get sensation to the xiphoid. So what happens with an injured spinal cord is it's not really sure what's going on yet. And so that level will change as, like I said before, as the injury completes itself. What's really the most important thing, it is important to document, yes, it was at this level, and that was done very well. But it's on us then when the patient gets to the hospital to continue to document as the injury evolves. But what is obviously more profound is that you have bilateral extremity paralysis. So, anything above L2, so he was a T4, anything above this level, you lose hip flexion, knee extension, ankle dorsiflexion, extension, and plantar flexors. To make the foot do this, are the sacral, kind of the end of the spinal cord. But this is the lumbar spinal cord, and so with an injury at this level, all of this is out. The cervical spine is where the ability to move our arms comes from, and so obviously that is intact and will be important for him in the future. I say. But just some examples of areas here, C5, think of the deltoid, sixth thumb, middle finger, and then little finger, that's the lowest nerve root of the ulnar nerve. And so that's on the ulnar aspect of the arm. That's kind of a good jumping off point to think of. T4 is nipple. And so nipple xiphoid pretty close to the same area. So once the injury had completed itself, that was the exam that we were getting, and that was reproducible. T8 is xiphosternum. Umbilicus is T10, which was the initial note. So you can just sort of see that things evolve even in the space of a few hours. But some more kind of important things on the concept of neurogenic shock. And I want to stress this. I guess obviously it's in red, but this is something that we take pains to teach the residents and anyone that's taking our advanced trauma life support courses, that neurogenic shock is always a diagnosis of exclusion. It is the thing that you come up with after you've definitively ruled out hemorrhage. So the top three causes are hemorrhage, hemorrhage, and hemorrhage for a traumatically injured patient, and that's why the next point is really true. In the pre-hospital setting, always assume hemorrhagic shock. And that was what was done in this case excellently. There was initial initiation of resuscitation from traumatic shock. I mean, there's really, what can we do in the pre-hospital setting for hemorrhagic shock? We can get wide bore IV access. We know that is the most important life-saving pre-hospital intervention you can do. There's nothing that has been shown in evidence to be as effective as wide bore IV access early. And then as you're coming, the patient got fluid resuscitation, and then when life flight got him, they gave blood products. So they managed the patient basically based on these principles. You always assume hemorrhagic shock, especially in somebody with a high spinal injury, because they may not be able to tell you that they have an abdominal pain. And it was noted in the run sheet that the belly was distended, and so absolutely assume a belly injury until we can rule it out, or a pelvic injury until we can rule it out at the hospital. But the pathophysiology behind neurogenic shock, and that's different than spinal shock. So spinal shock is a totally different entity that is basically a stretch of the cord or a stretch of some of the roots that presents with a loss of sensation or motion, but there's no anatomic defect. In other words, there's no actual injury, but the cord is stunned. And those almost invariably get better over the course of a few hours. Neurogenic shock, however, is because you have spinal cord compromise. And that's the upper thoracic and cervical spine that can cause this. So you generally will not see neurogenic shock below the level of T6. And I say T5, 6 because there's debate about at what level the cardiac accelerator fibers actually innervate from. And some people will be down to 6, some people will be down to 5. And what that means is some people will have a T5 injury and have no neurogenic shock. Some people will have a T6 injury and they will have neurogenic shock. So I think that's why we can't pinpoint it exactly, but it's any level above that you will see it, or you can see it. And the reason is that the cardiac accelerator fibers um, are sort of directly arise off of the T1 through T5 spinal cord. And not only that, you lose transmission to the sympathetic effect on peripheral vascular tone. So everything dilates in neurogenic shock. And so that compromises preload. And also, so if you think about the situation, you have inability to return blood back to the heart in an effective way. And the heart itself can't pump effectively because in this scenario, the patient should be running at like 120, 130 a minute. But that's not the case. As you could see, going back to the initial case presentation, his rates are in the 40s intermittently. And that's another kind of telltale of neurogenic shock is that it gets better for a second and then it comes back. And you see this sort of fluctuating pattern as the injury evolves, which is exactly what we saw in the vital signs that were reported on both the teams' run sheets. So interesting. In the first step, no matter where the patient is volume resuscitation, and so that's what was done in this case, and you could see that he responded initially to the IV fluids in the ambulance, and then again to the PRVCs and FFP in the helicopter. And now he's in the ICU still, and he does require a low dose of vasopressor, despite the fact he's euvolemic and his hemorrhage has been controlled and all those things, because not only does sedation really affect somebody who doesn't have any sympathetic tone to the peripheral vasculature, but also there's just that inherent pooling. Interestingly, we put tubagrip compression stockings around his legs, and that actually helped his overall hemodynamic picture because it allowed us to compress the peripheral vasculature, at least in the soft tissue below the knees. So at any rate, the first step in any shock is volume expansion, and even in neurogenic shock is no different. When we transition out of the trauma bay and we have the injuries identified and we have the hemorrhage stopped and they're still in shock, then we add vasopressors. But that's in tandem with ongoing volume, we will do both. And that's because vasopressors can restore the squeeze peripherally, especially something like norepinephrine or phenylephrine. But that also can lead to volume loss that takes the patient out of the euvolemic picture. So in other words, vasopressors have to be very carefully used in neurogenic shock, and they should always be used with volume expansion and after volume expansion has been initiated. Um, just a couple of other notes, and I think this patient is a clear-cut example of this, where the relatively narrow canal in the thoracic spine is it just creates a high risk situation, and there are more complete injuries in the thoracic spine, whereas in the lumbar or the cervical spine, there's more space. So those tend to be, or at least are at more of those injuries will be incomplete in those two other locations. And again, the inability to perceive pain can mask acute abdominal pelvic injuries. Um, and I think, oh, and we'll talk about this here too. So that's spinal cord injury and neurogenic shock in a nutshell. I just didn't want to touch on this real quick, and just kind of make a note of how this man's chest was managed. Um, in both run sheets, in both the ambulance and in life flight, they they clearly stated there was equal chest rise bilaterally, and there was lung moving bilaterally, and that there was no JVD, and that the trachea was midline. And so, because that was the case, neither team um, pursued needle decompression. And I just want to say that was absolutely the right call to both of those teams. It would not have benefited him. It would have potentially risked underlying injuries. You can see how unstable that chest wall is, injuring the lungs or the heart or the diaphragm. And just based off their field diagnoses, they were able to come to the point where and decide that, like, yes, this is not a tension pneumo situation, which is the only indication for pre-hospital needle decompression. The basic pathophysiology, I think we've covered this a few times, but in case, uh, just to review it here real quick, lung injury, laceration to the lung tissue results in one-way positive pressure air influx into the chest cavity. If there's any backflow, it creates a pneumatocele, which is what we saw on his CT chest earlier. That positive air pressure accumulates in the pleural space and increases both the volume and the pressure with each breath. Probably one of the things that may have prevented tension physiology in this patient was that the air had egress out of the chest wall, which is kind of an interesting thing to think about. But all of this air down here was pneumothorax until it made it outside and into all of his tissues. And But if that's not the case and there isn't significant disruption in the muscles between the ribs and the air can't get out, you can get a really significant positive pressure evolution in the chest. And it doesn't take a whole lot to compromise preload. We know that central venous pressure is somewhere in the 8 to 12 range, right? And so you don't need a ton of pressure to overwhelm that. And so what happens is that pressure evolves in the chest, blood can't get back in, and then you lose preload, the heart's struggling. And that and that is really what causes the obstructive shock picture of tension pneumothorax, and then that can lead to cardiac arrest if it isn't fixed quickly. So in the field, you'll see hypotension. We saw hypotension, but the breath sounds will be decreased or absent on the side that's affected. It may be hyperresonant. There will be tracheal deviation away because the whole mediastinum is shifting away from that high pressure side. And there will be neck venous distension because, again, the pressure is too high to allow blood to come down from the neck and through the SVC to the right side of the heart. The chest is typically expanded and immobile. And, you see very narrow pulse pressure with these. And that's sort of, unless you're seeing those things, then the needle is not going to help you. And so that both teams recognize that and just worked with supporting him with supplemental oxygen and an airway. And then if you are putting one in, I just wanted to throw this slide up here to talk about safe placement. You'll notice that the mannequin's arm is up and the hand is either behind the head or wherever. But what's important to note is that the arm is elevated and it's abducted away from the axilla, and that brings soft tissue into the right position for finding the landmarks. The pec major is the anterior border, latissimus is the posterior border. This is the line defined by the nipple. And in general, this is the mid-axillary line here. In general, you want to be somewhere in this space, right about there, for your decompression to be safe. You should not be below the fifth. We know, the heart lives here, especially on the left side. So fourth or fifth intercostal space right here is where you want to be targeting. And I've talked about technique in other lectures, so I think we'll move on. And these are the references. Any more questions?
We did have one pop up in the Q&A. Would there ever be a case for tourniquet in a closed femur fracture, knowing that the thigh can hold that much volume?
That's a good question. I think I would answer no. In that case, the thing the patient needs is blood. If you have a transmitting pulse, a tourniquet's not really going to help that situation. The point of a tourniquet is to prevent ongoing loss, either from an open fracture or an amputation. So it really isn't indicated in closed femur fractures.
Excellent. Let's see if there's any others. There's some thanks from the ski patrol team that were on that original case. So we appreciated that.
Well, thanks back to them. Thank you guys for doing what you do. Everybody, really. I mean, there was a lot of really, really great work and a lot of very sick patients, very difficult management environment. I think I just want to applaud everybody that does this for the state of Maine. Like we're lucky to have you out there.
All right. Lots of thank yous. Lots of thank yous. Oh, here we go. How would patient perceive air leakage? Is it pain or pressure?
I'm sorry, one more time, Eric.
How would the patient perceive their air leakage? How would they feel it? Would it be pain or pressure?
An air leak? You mean out into the soft tissue?
I believe so, yes.
Yeah, that will present as crepitus. So it feels like there's Rice Krispies under the skin. And sometimes they'll look really swollen like a toad. It takes a while for like the neck. When I say that, I actually mean like a toad, like the neck swells, the face can even swell because this stuff tends to infiltrate and move upwards. That does take a while to evolve though. So in the immediate, like post-injury, like on scene, there's a chance you won't see that necessarily. But that's what it'll feel like. You'll see the skin, the chest looks swollen, the neck will look swollen. And if you push on it, it'll give, and then it'll feel like there's Rice Krispies under your fingertips, which are actually the air bubbles in the tissue.
All right. Well, that looks like the questions for today. So we'd like to thank everybody for attending. And thank you to Dr. Shurtleff for, again, presenting another excellent presentation.
You're very, very welcome. It is my pleasure. And again, thank you to you all out there keeping us safe.